Wow. This is good. Oh, thank you. Y'all got a dark one? Thank you. All right. So we're gonna run through hormone receptor positive, HER2 negative, make sure we didn't leave anybody from last time on that one. Okay, we're still talking about stage 1, 2, and 3 patients. One thing to remember, like this whole chart is actually focused on patients who have stage 1. Okay, so this is really like stage 1. So if you notice, there's no chemotherapy per se mentioned in any of these treatment pathways because all you do mainly is do either radiation or surgery if you're in the early stage and you're only doing lumpectomies. It's not until we get to stage 2 and 3 that we really start diving deep into like the chemotherapy and systemic therapies. The patients who have stage 1 will possibly get endocrine therapy though if they're hormone receptor positive. So what are the examples of endocrine therapy? What are our options? So you have tamoxifen, you have aromatase inhibitor, and you have what? LHRH agonists. Okay. So how do you use tamoxifen? 5 to 10 years. Okay. What about an AI? 5 years. It can be 5 or 10 years, but for AIs, you can't get away with 5 years. It's the tamoxifen, that's a lot of data with 10 years. Now, what about the LHRH agonist with an AI? Why do you use that? Where does that come into play?
So you use it in pre.
So you use it in pre or peri, right?
Yeah.
That also typically about 5 years. So it's really the tamoxifen that's got that 7-year marker where you really use, like you end up using like 7 years of tamoxifen. The AI and the AI with the LHRH agonist, the most data lies in the 5-year time frame. But in tamoxifen, it can go all the way up until 10 years. But we try to keep them on at least 7. So stage 3 patient, what about the chemotherapy? What do we use there? What chemotherapy we used the other day? Those things, AC, followed by Taxol. And these are some of the doses that you'll need to know. So what's the dose of adriamycin? 6 milligrams. Correct. And what's the dose of cyclophosphamide? And what's the dose of the weekly Taxol? Okay. So let's say that our patient, that stage 3 patient that we talked about on Monday, is 166 centimeters tall, and they weigh 91 kilograms. Okay. What is their dose of adriamycin? What's their dose of cyclophosphamide? And what's their dose of Taxol? Anybody got anything? What's the first thing y'all need to do? Calculate the BSA, okay? So what are the equations that can calculate BSA? The most stellars, and then what's the other one called? What's called GHAN, okay? But we use most stellars. Most clinically practicing individuals use most stellars, but you can't use, GHAN is only gives you like a 1 to 3% difference in the BSA when you calculate it with GHAN. So let's use most stellars. So what's most stellars equation?
The square root of the height in centimeters times kilograms divided by 600.
That's correct. Okay, so what y'all come up with the patient's BSA? 2.04, 2.05. Okay, so what are the doses?
22 milligrams for adriamycin,
Okay, I can go with that.
1,224 for cyclophosphamide.
Yeah. We get around into 130 on that one. What about the Taxol?
163.
Okay. We usually round down to the nearest 5 or the nearest 10, depending on the vial size. It's not your responsibility at this point as you're learning to know when you should round to which vial size, so on and so forth. But I can guarantee you on Monday, you're gonna have to know how to calculate BSA, and you're gonna have to know how to calculate the dose of said drugs here. There'll be a couple more doses that you'll end up needing to learn, but yeah, these are 3 of the main doses that you'll need to know. So you'll get the patient dimensions, and then you'll have to calculate the BSA to then come up with the dose. Does this make sense to everyone? Okay. So,
Hold on.
okay. Okay, so y'all ready? So let's revisit again radiation. When does a patient qualify for radiation? For breast cancer. Positive margins. Okay. So the reason you saw radiation scattered throughout the local, the stage 1 patients is because those patients, the standard of care as far as surgery is concerned is a lumpectomy. So that's why that's why you saw all the radiation scattered throughout with those early stage patients. So now I want to give us a new patient. We'll still make them stage 3. But now, instead of being hormone receptor positive, HER2 negative, now we do have amplification of HER2. So now the hormone receptor positive, HER2 positive, or what we refer to as triple positive. Okay? So what drugs are going to be added to the party now? CDK4/6 inhibitors are limited to hormone receptor positive, HER2 negative patients with the Ki-67 that's above 20% and have lymph nodes that are positive. Herceptin and pertuzumab, and possibly Kadcyla. One of those 3, or 2 of those 3, depending on which combination you use. Okay, so now there is regimens that look exactly like the one that we had there. But the most important regimen on this particular type of breast cancer is a regimen called TCHP. Okay? The T stands for Taxotere. C stands for carboplatin. The H stands for Herceptin. And finally, the P stands for pertuzumab. Now on this one, you usually give patients 6 cycles. And each cycle is every 3 weeks. Okay? And then that's followed by enough H plus P to complete one year. Now, doses. $75 milligrams per meter squared on Taxotere. Carboplatin is special because it uses something called the Calvert's formula. Have y'all ever heard of this formula? Calvert's formula? This is the first time y'all hearing that? So the Calvert's formula is a validated equation that takes into consideration the patient's creatinine clearance and the area under the curve that you target in reference to your dose of carboplatin, and it gives you a dose of milligrams. So the Calvert's formula goes like this. So you have your dose in milligrams is equal to your desired AUC. Okay, your desired AUC, but you want to multiply that by the creatinine clearance plus 25. So the 25 is the non-renal clearance of carboplatin. So patients will have a steady state clearance of carboplatin that's not related to their kidneys of 25. The creatinine clearance goes up and down depending on the function of the patient's kidneys. So if you have patients that have very good renal function, their carboplatin dose is higher. You have patients that have a lower amount of renal function, their carboplatin dose is lower. So platinums in general, you're very mindful of how well the patient's kidneys work. But with carboplatin, they have a validated equation that will help to protect the patient's kidneys by giving them lower doses if they filter it at a slower rate. So let's use our same patient here, same dimensions. We're gonna say she's a woman. We know she's a woman, and also, in addition to being a woman, her serum creatinine, we'll say, is 0.89 milligram per deciliter, and we'll give you her age of 53 years old. So we're gonna put on TCH plus P, so now you should be able to calculate the dose of all of the chemotherapy. This pertuzumab is a flat dose. So it's 840 milligrams for the loading dose and 420 milligrams for the maintenance doses. And her Herceptin is 8 milligrams per kilogram for the loading dose. And then the maintenance dose is 6 milligrams per kilogram. So it's pretty relatively easy to calculate the doses of the monoclonal antibodies because one of them is a flat dose, doesn't matter the size of the patient. The other one is just a milligram per kilogram dose. The dose calculations that are complicated are mainly the carboplatin and the Taxotere. So what's the dose of the Taxotere?
75 milligrams for the top 6 cycles.
No. So the 6 cycles is just the duration. We're gonna get to like how to give you guys the information about the duration, but I'm just talking about the dose of the Taxotere compared to this patient's dimensions, like what's the dose for one cycle? Because y'all just calculated a VSA. Right. It's just 2.05 times 75. So this dose here is Y'all said what, 153? We'll say 153. Does everybody understand we got that? 75 milligrams per meter squared with these dimensions gives you a BSA of about 2.05. Okay, so that's where we get the 153 from. Now the carboplatin, that's the doozy, or that's the one that usually even clinicians will sometimes get tripped up on how to calculate this. But the first thing we need to do is how do y'all calculate creatinine clearance?
Weight times
0.85 in a woman, yes. Okay. If it's a man, then the 0.85 comes off. That's why I gave you these additional variables, because I want you to use the Krakow-Gault equation to calculate the patient's creatinine clearance. Okay? So y'all give me a creatinine clearance for this patient. Make sure y'all want I haven't calculated it yet. Okay. So what do you have thus far? 105 is what I hear. Okay. Anybody else? Any other concerns? Any other thought processes behind why it might be different than 105? So when you guys are dosing drugs, have y'all been taught the concept of looking at the patient's actual body weight compared to the ideal body weight? So in that conversation, what ensues? Like, what did they talk to you guys about? Say what? Anybody? Or they? So whenever you're looking at drugs, unless it's a drug that specifically says and has data that says that you have to use the actual body weight, you actually want to compare the actual body weight to the ideal body weight before you make your final decision on how you want to dose it. So some will say 20%, some will say 30%. Really, when you guys were talking about antibiotics, I'm hoping that y'all just forgot. After y'all had all of those lectures about antibiotics, that nobody introduced the fact that you need to look at the actual body weight versus the ideal body weight. And if you see a difference that's above 20 to 30%, then you would use possibly adjusted body weight. So in this scenario, we're using adjusted body weight. You'll see some centers that will use ideal body weight when you're talking about antibiotics. That's why I asked y'all that question. You should have learned it when you talk about antibiotics. There should have been a conversation about if a patient's actual body weight is above 20% of their ideal body weight, then current practice is typically use ideal body weight to dose the antibiotic. That's pretty much a hard and fast rule. That's like whether you go to Morton Herman or MD Anderson, wherever center you go to, whenever you come to rotations, they're not gonna just dose every antibiotic with actual body weight, especially if the actual body weight is a certain percentage above the ideal body weight. So in cancer and oncology, we actually use 30%. So when you look at this patient's actual body weight, it's 91 kilograms. Their ideal body weight is what? Y'all know how to calculate that?
Yes.
45.5 kilograms plus 2.3. And that 2.3 is gonna be the difference in the patient's height compared to what? 5 feet. So however much taller they are than 5 feet times, that's the amount of inches. However many they're tall versus 5 feet, you multiply that by 2.3, you add that to 45.5. And then that's gonna give you your ideal body weight. So the ideal body weight is 57.81. Yes.
How would you guys, I'm not trying to bring it back, but you got this one,
153 is the body surface area of the patient multiplied by the 75 milligrams per meter square.
Oh,
When I do body weight, there's also the other one that's like, the height centimeter minus 1.5 for male and. 108 for female.
The standard one we use is the 45 or the one that's got the 50, if it's a male. And it's gonna be compared to like whatever the difference in the height is over 5 feet. So for a female, 45.5, difference in height 2.3, and that's gonna be added to the 45.5. And that's where the 57.8 comes from.
so in this case, you don't approximate it, you just leave it that way or what?
Which one, the 153?
Yes.
I mean, you don't, I'm not gonna harp on you guys rounding to the correct place. You just wanna make sure you get the doses closest to it, yeah. But the important thing about this patient and the Calver's formula is that when you're calculating creatinine clearance, you actually need to use adjusted body weight because I made the patient's weight over 30% of the ideal body weight. So that means you need to then calculate the adjusted body weight. Y'all thought y'all was done with all of this math? Nah. Yeah, I use every single day that I go into the clinic, I calculate multiple doses, take multiple considerations related to mathematical equations. So some doses maybe some equations y'all may have learned they were ridiculous or not necessarily needed, but you use these in clinical practice very, very frequently as a pharmacist. Nobody else is doing this but you. The physician is just signing off. This is all y'all, okay? So adjusted body weight, ideal body weight, okay? The Krakow-Gauss equation and the Calver's formula, those are like the equations that you need to know. So let's talk about the adjusted body weight. So 45.5. That's gonna be plus that 2.3. And that 2.3 is really just the difference. It's the difference between whatever the patient's height is in inches and the actual height. So if the actual height is in her case 166, okay? 166 is her height, so we need to put it into inches. She's 65.5. She's like 65.4 inches. You want to minus that by 60 inches. Okay, so that's how I'm getting that. That's why I'm getting the 57 from. Does everybody understand that?
Is that for the ideal? Or that's
This is the ideal body weight, which needs to be compared to the actual body weight. So now that comparison I was talking about, if her weight is 91 and her ideal body weight is 57.
So no rounding to 58, just 57?
I mean, it could be 58 or 57. It's still going to go above the 30%. So what percentage is it above? nobody knows or nobody, huh?
Like 57%.
Correct, 57%. Y'all know how we did that? Yes, no, baby, so.
Yes.
Y'all got a test next week or not? Y'all tell me, man. I already got my license, man. So are y'all trying to win or y'all what y'all doing? Y'all let me know, man. I see a lot of blank stares, man. So you can tell me what you don't understand or let me know something. Or I continue to keep going. Because 57, that's correct. That means we need to do what? We need to use what? We need to use adjusted body weight to calculate the creatinine clearance to get the dose of the carboplatin. So 105 was the dose of the creatinine clearance with the actual body weight. I want to know the creatinine clearance with the adjusted body weight. So you got, go ahead.
57% again?
Huh?
How do you get 57%?
You gotta just compare the 91. If you do the 91 divided by the 57.9, you get 1.57. So then anything above the 1 equals the 57%.
91 divided by 57.9.
Mm-hmm. Then you should get like a 1.56 or 1.56 something.
Yeah.
So everything above the 1 is actually the percentage it is above the ideal body weight. And that's important because you want to, anything above 0.3, 1.3 lets you know you need to use adjusted body weight. Okay, let's see what we got. Well, what the first thing you want to do is what's your adjusted body weight? 70.6. So adjusted body weight, 70.6. And that's the weight that you're going to use to calculate the creatinine clearance. Yeah, 81.47. That's using the age of 53, a serum creatinine of 0.89, and the adjusted body weight that we've already calculated to be 70.6. So if I tell you that the creatinine clearance is now 81.47, then what is our dose for the carboplatin?
So you said AUC times creatinine clearance plus 25?
Well, so the creatinine clearance is added to the 25 and that's multiplied by the desired AUC to give you a dose of milligrams. There still should be one question that everyone is asking.
What's the desired AUC?
What is the desired AUC? Okay. The AUC in this particular one is 6. Y'all gonna be asking Dr. Bobo for extra time, man, on Monday. I can see that already.
Can you just let me know?
We practice it right there.
It's hard to understand for me, cause it's all jumbled up, like with the problems that come to actual page.
I mean, we can do another one after this, and I won't write anything. I'll let y'all walk me through what to do with it.
Can we do another one?
Huh? So what's the AUC? What's the dose?
600.
That's correct. Okay, it's like 636. You can round it to 635, or you can leave it the same way. Okay. So the dose of the carboplatin is 636.
639. Almost, yeah.
Okay. Now,
What's the dosage for?
the dose for the carboplatin is 636. The AUC is 6. It's easy enough to do the dosage of the Herceptin and pertuzumab, but I'll do them anyway just for completeness.
It's 6:38 or 9. It's 6:39 almost.
Well, I mean, you would end up, essentially you round it down to the nearest 5 to 10 anyway. So unless it rose to 640 something, it really wouldn't matter if it was 636, 637, 638, or 639. Also, when we're calculating the dose, and this is what the infusion pharmacist is doing, not necessarily me, but if I send them the dose of 635, or if I send them the dose of 636, when they calculate they get 638, they're still gonna they're gonna make the bag for 636 because it's within a 10% threshold of what I've calculated. So the nurse, the infusion pharmacist, the clinical pharmacist, and the physician might all get different doses, but as long as they're within 10%, nobody is gonna ask the other person anything about it. Does that make sense? So as long as your dose is within 10% of this, it's right. So the loading dose for the Herceptin would end up being 728. This is for H, this is the loading dose. Then for H, for the maintenance dose, $546. So the doses,
This 636, where did it come from?
that's the carboplatin
I
dose.
know, but how did we get it? Because I did the AUC times the creatinine clearance plus 25, but what was the dosage of the carboplatin?
Well, I mean, when you do the 81.47 plus 25, you get 106. And you multiply that by the desired AUC, and then you get like a 638.8.
Okay, so that's
Yeah,
what
yeah.
changed. There's
Yeah,
no
yeah, I mean, yeah,
actual
that's why I was
dosage
telling her that,
multiplied
like,
times.
yeah.
Okay, that's what I was looking for.
Yeah, that's it. Yeah, so she got 630. That's why I told her, like, as long as it's within 10%, it's fine. Because if you take off if you round early, your dose actually changes a little bit. That's why we don't really harp, but as long as it's within 10%. If it gets outside of that 10%, then we got a problem. Okay, so y'all want to do another patient, right? Yes. Okay.
What was the maintenance dose? The loaded dose was 636?
Well, this is carboplatin. Carboplatin is 636. The Herceptin loading dose is 728. The Herceptin maintenance dose is 546. I'm gonna leave some things up here, so I don't gotta write them again.
دیگه متن دوم دبستان.
فقط چون خیلی قرقاتی می‌نویسی اصلا
Okay.
ولی من دوباره که پیش میاد.
چون خیلی چیه آقا
You said what did I have when? Oh, so Sure. So that loading dose and that maintenance dose was the 8 milligram per kilogram multiplied by 91, and that 6 milligram per kilogram multiplied by 91.
Oh, okay.
So the first dose, yeah. Actual weight. So that's a good question. That's actually why I made a disclaimer of when you use which weight. I use actual body weight when I calculate the dose of the monoclonal antibodies, because that's how they were studied to be dosed. We only adjusted the body weight on the creatinine clearance equation because those equations are validated with patients not being obese and being morbidly obese. So once they get to being morbidly obese, then you take into consideration usually adjusted body weight. So it's really just the creatinine clearance that you have to worry about the adjusted body weight being used. If you're calculating the dose of the monoclonal antibody, you're actually going to use the same weight that you get regardless of what it is for the patient. Okay, so I'm gonna change the patient dimensions a little bit. We'll still leave it as a woman. Okay. Let's make her 82 kilograms. Let's make her 157 centimeters tall. Let's make her 42 years of age. Okay. So I cleared the board also to see how much exactly y'all were listening earlier. So, what are some things that y'all know we're gonna need? What's the first thing we should do? We should calculate the BSA. We should calculate the BSA. Y'all know y'all gonna need that. So we're gonna calculate the BSA. And y'all gonna tell me what that is. What else y'all wanna do?
Male or female?
It's male or female?
It's a female again.
Female.
Okay. So what else might y'all need besides BSA? Creatinine clearance.
Your ideal body weight?
Your ideal body weight. What else?
AUC.
Well, when y'all say AUC, what you're really probably saying is like what regimen are we using? Okay, because I don't have a regimen up here. So what regimen do y'all want to use for this patient? What regimens do y'all know for patients who have HER2 positive disease so far? Okay, that's it. T, C, H, P. Okay. Maybe I'm gonna write it like this so it's a little bit easier. T, C, H, and P. Okay. So, what's the easiest dose to come up with for what we discussed?
It's P.
Is it Herceptin
No, P.
or pertuzumab, which is a loading dose of 840 milligrams, no matter the size of the patient, followed by a maintenance dose of 420 milligrams every 3 weeks. Okay. Everybody agree with that? So now I heard Herceptin. Still easier than Taxotere and carboplatin. So loading dose is what? 8 milligrams per kilogram, which means 8 times 82. So what y'all get for that? Should be 640 something, 650, what is it? 660? 660. 656, okay. Maintenance dose is what? 6 milligram per kilogram. So what do y'all get there?
How do we get that 656?
656 is 8 milligram per kilogram times 82.
Okay.
What's the maintenance dose?
492.
490 what? How are we doing right now? Is everybody good?
Yes.
Okay. Make it make sense. Okay. What'd y'all get for the calculation of the body surface area? Okay, I agree. So what else can I calculate now that I had a body surface area?
Taxotere.
The taxotere, right, which is dose of taxon. So what dose is that?
141.7.
We'll even put the 0.7 on there, that's okay. All right, so I got one left. Okay, what AUC are we targeting with this regimen of carboplatin?
6.
6. AUC of 6. And what is the Calvert's formula? It's the dose in milligrams is equal to the desired AUC. Okay, and that's multiplied by the creatinine clearance plus 25, which is what? What's 25? That's the non-renal clearance of carboplatin. That's the non-renal clearance of carboplatin. So still some things there that we need to work out, right? But we have 75% of the doses already. So let's go to, look, 157.
Dr. Hunt, where do you get the 75 from?
75 milligrams per meter squared. That's a standard dose of taxotere for the TCH plus P regimen. So 157 equals 61.8 inches. Does everybody understand how I got that? 157 centimeters equals 61.8 inches. Yes? No. Thank
Right
you.
on the board, please.
Yes. Huh? Huh?
That, body surface area.
Uh-huh.
You used which one to divide it to get that very one purpose?
The body surface area is using the Most-Stellar's equation, which is taking consideration.
Okay, most of this.
Okay, yeah, the Most-Stellar's equation. Okay, so now, this 157, so the 157 centimeters divided by 2.54 equals the 61.8 inches. This is just the conversion factor from centimeters to inches. Okay?
What was the standard regimen for the loading dose and maintenance dose?
Pertuzumab is 840. This is how it's always going to be. It's a flat dose of 840 for the loading dose and 420 for the maintenance dose. Always. It never, even if the patient has toxicity, it's still 420. So they either get it or they don't. It's at that dose. Okay? So now we know that we have 61 inches there, and the reason why we need the inches is because we need to estimate the ideal body weight. So, I get 49.64. What do y'all think about that? Compared to the actual body weight? Hmm?
Compared to 65.
64% above. So 64% above, the actual body weight is 64% above the ideal body weight. Does everybody know we got that? No. Okay. So you take 82, which is the actual body weight, and you divide it by the ideal body weight of 49.64. It gives you 1.64. Whatever you get above 1 when you divide these two together is the percentage of the actual body weight that's above the ideal body weight. So 64% above the ideal body weight because the answer is 1.64. Now you need to use adjusted body weight.
Yeah, use adjusted, right.
Now you need to use adjusted body weight to get the creatinine clearance. Okay, so we got one more. Now that we got the ideal body weight, we see that it's too high of a percentage. We need the adjusted body weight.
Okay, so, when will we stick with the ideal then?
Never.
Never.
It's either actual or it's adjusted. Talk to me.
What's the threshold for the percentage?
30% or above. 30% or above.
$62.54 for your adjustment.
Let me see. Yeah, I got adjusted body weight of 62.6. Which is what we're gonna use to calculate the creatinine clearance. They stop me if something doesn't make sense.
What did you get?
62.6.
49.65 plus.
Whenever you're looking at the adjusted body weight equation, you're looking at the ideal body weight added to 40% of the difference between the actual body weight and the ideal body weight. So whatever that difference is, you take 40% of that, you add it to the ideal body weight, and that gives you the adjusted body weight.
101.91 milliliters per minute.
For the creatinine clearance, let's see. One oh two.
I don't know when you round it. We get noticed.
That's the thing about it. Like whenever you round, if you round early versus late, it's gonna slightly change the answer. And that's why we always have the 10% threshold.
So you wanna go to 102?
So what's the AUC now? We got everything we need now. After all of that. Bless you.
AUC was 6, right?
Yes,
So now you just wanna know the dosage of the color
yes.
752
Okay.
milligrams.
There was a question? The 102 is just the creatinine clearance, but it's a creatinine clearance calculated with a weight of 62.6. So the 102 is the creatinine clearance, but it's just the body weight, not the actual body weight.
No, santo.
I mean, I use 62.5 because I round, I'm still
Sure. Sure. So the non-renal clearance is like it's a constant. So every patient, no matter who in this room gets carboplatin, they pretty much clear carboplatin at that rate. And it has nothing to do with their kidneys. Okay? But their kidneys, as they change functionality, it differently changes the amount of carboplatin. So that's why that number needs to change.
ولی بازم پی نمیشن 5 ساعت
سیروم کریاتینین چنده؟
0.71
آه
0.71
آها 0.71 من گوشتم 102
What's the next step after the what? You said after you get the creatinine clearance, what's the next step? The next step after you get the creatinine clearance, when you're trying to calculate the dose of the carboplatin, is to add the creatinine clearance you calculated to 25. Once you get that number, you then multiply that by the desired AUC, which in this case is 6. And then that's where that 762 comes from.
We got to come in there. That's what I
Oh, yeah. That's one.
But the whole thing, though, like, if you at least give us like
Oh, yeah. Huh? You said give you the adjusted body weight.
Yeah, can you just give us that part so we can just, you know, these integrated
That's gonna take us.
It's already on the list of questions.
Stressed out.
But they gonna give us extra time?
Can we get the formulas too?
Can you separate?
خب من چرا
Can I separate my part from the integrated weight?
بعد از سر چیزشون هم
آه 85
Oh, he told me. He told y'all to call you.
You were the head of cheese, he said that's not you.
You called my first and last.
If we just believe that your question separate.
So you want pretty much want my part of the exam to be not part of the integrated exam? Is that what you're saying?
Or get rid of it.
Or just stop integrated.
Because it's not integrated, it's not integrated.
That's true too. Well, okay.
Moi, donc c'est sur les bases.
I know. So here it is. So as far as the integrated exam, I'll talk to Dr. Bobo. Number one, I already told him that I have a lot of math on mine, so that y'all need extra time. So I did already address that. As far as bringing all of my questions out of the integrated exam altogether, that's not a conversation that we've had, but I can start that conversation today, but to see if it's realistic for it to be brought out of the integrated exam.
Or just separate PT and POTA, like let's just stop the integrated.
I understand that tends to be better with the fact that the POTA is not integrating well with this class. So that's also been a conversation. I do know that when we get to the new PT, not this one, but the next one, I know that it's not integrated because I've already looked at the schedule.
It's
So,
never been integrated.
well, I'm saying I know that it's not been integrated because I looked at the schedule. The reason he's sending y'all to me because he's now appointed me to chair the curriculum for me. That's why he sent y'all. That's why all of a sudden
He's good at
sent
that
me.
anyway.
Huh?
That's his specialty.
Oh Lord. So this is what I'll say. I talked to Dr. Bobo about the taking out his class from the integrated. That's his prerogative. I can't make him take the class out. I can make the recommendation because it's not integrated, which we do know that. We know that to be true. So I talked to him about that. I also you will have extra time. As far as like you getting the equations, I give y'all the benefit of that. I give y'all the equations. That way, just you being able to use them correctly. So you'll have all of the equations. You'll have the created clearance, the ideal body weight equation, the adjusted body weight equation, the Calvert's formula. I give you all the equations. So you have all the equations. You're still gonna have to know how to use them.
Can we use our own calculators, or do we have to use one?
Yeah, the one inside it's not the same, so please vote for us to use our own.
Yeah, exam self calculator is not working, but yeah.
It's not good.
It doesn't have a square root.
It's not a scientific calculator. Who's y'all's class representative? You the class. Can you send me a email just specifically saying what they're talking about with the exam soft calculator, so that I can then communicate that to the faculty so y'all can use y'all's own calculator.
Thank you.
Okay?
Zoran is good with numbers.
small iPad mini. Yes, I'm come back. iPad small.
Katucciolo in iPad maybe.
Okay. So I realize that I've heard from several individuals that y'all want more practice with this. So I'll make y'all some patience to serve as like a quiz for this course. So I'll make y'all like 3 or 4 patients. We'll have each type of the breast cancer, and y'all have to calculate all of their doses for their treatment. Okay? So I'll upload that today. I'm gonna upload the areas of concentration anyway today, but I'll upload also the practice problems. It'll have 3 to 4, and pretty much each patient is gonna be one of the 4 types of the patients that y'all will have to work with. Okay? No, there will be a few questions on cervical cancer. So that's I have a few questions on cervical cancer, but don't worry, they have some, they're pretty much BSA calculation questions, and then there's maybe 1 or 2 that are outside of that, but we're gonna talk about that in this last couple minutes, okay? And then we'll revisit it in the lab also. But before, we can't get to that until we first make sure you guys understand this part. So if y'all recall, I said that how many cycles do they get of this?
6.
So when they get 6, and how often do they get these 6 cycles?
Every 6.
So total, how many weeks is this?
18.
18 weeks, okay? So this is 18 weeks. Okay? And how many weeks are in a year?
365.
That's 52. Okay? So what's the difference between 52 and 18? What's the difference between 52 and 18?
It's 34.
34? Does everybody agree with that? 52 and 18, 34. The maintenance therapy that this patient is required to get is 34 weeks of Herceptin and pertuzumab. That's why I'm asking you all these questions. So they get 18 weeks with the chemotherapy of the Herceptin and pertuzumab. But the regimen calls for enough Herceptin and pertuzumab to complete 1 year. Okay? So to complete that 1 year, they need to get another 34 weeks. Do you understand? So some of their maintenance, so they got from the year was with the chemotherapy. But we don't give them the chemotherapy for a whole year, their body can't tolerate it. So we give them 18 weeks of chemotherapy with the Herceptin and pertuzumab, and then after that, we then go to the point where they're just getting these 2 to complete a year, or 52 weeks, which translates to 34 weeks remaining. That's very important. The TC with the HP is for 6 cycles times 3 weeks, or 18 weeks. After they complete the 18 weeks, they then get more H plus P to complete a year, and that's where you get the 34 weeks of it. Yes,
Who said that? Nah, TCU.
that's maintenance though.
TCU 18 weeks.
6 milligrams per kilogram every 3 weeks.
Digester.
6 milligrams per kilogram of trastuzumab, 420 milligrams flat dose of the pertuzumab.
Every 3 weeks for 34 weeks,
Mm-hmm.
right?
Right. Yeah. They usually end up week or two off, get a delay here, get a delay there, but you're trying to complete 1 year. So what I do in clinical practice is when I start my patient on cycle 1 of TCH plus P, I write down the date we started. We started on January 10th of 2022. The end date for all treatment is gonna be somewhere around January 10th of 2023. And I know that encompasses chemotherapy, maintenance therapy, all those things. We should be finishing around a year from the day that we start the TCH plus P. Even though we're only gonna do the TCH plus P times 6 cycles. Okay. Yes.
Just to reiterate, so we do that for 18 weeks, and you said we do the Herceptin and pertuzumab for the remaining 34 weeks?
Yes. Yes.
The maintenance dose?
Maintenance dose every 3 weeks.
It's steady for.
Mm-hmm. That's correct. They're gone. They're gone. Okay. So I'm gonna, let's see. Okay, I don't got 13 minutes. So couple things. So one thing I'll add to this before I go to the next group, and we won't have time to calculate the doses, so I'll probably just give you the therapeutics of it. You get a nice review. I'll make sure you guys get a nice review in lab, okay? But I'm gonna give you the areas of concentration today. So this is one path a patient can take. Y'all remember what neoadjuvant versus adjuvant means?
Yes.
So this patient gets neoadjuvant treatment, right? So they get neoadjuvant treatment, and then we go in and we see if the patient has responded and had a complete pathological response. That means the cancer has essentially melted away just from the simple fact of getting the systemic treatments. Now, if they have something called residual disease, meaning the cancer still remains, then that patient can possibly get something called Kadcyla. If you recall correctly, that was the third drug that I gave y'all that targeted HER2. And it's a conjugated drug that's got an antimicrotubular chemotherapy payload in it, okay? We can leave it stage. I'm talking about triple negative patient now, but that HER2 positive that I was just talking about, that's Kadcyla. So what we do with the Kadcyla, same patient population that we just spent, the past hour or so talking about, is instead of doing that maintenance Herceptin and pertuzumab, we replace it with Kadcyla if they have residual disease.
14 or 18?
14.
Okay, and this is
I don't transfer
D. The Spanish.
HER2 positive patients. HER2 positive patients with residual disease, you can replace the HP maintenance with Kadcyla maintenance. Okay. Replace the HP maintenance with Kadcyla maintenance. This is the Catherine trial.
So they're still a neoadjuvant patient.
Well, whenever they're getting the maintenance, all of that's adjuvant because surgery has occurred at that point. Mm-hmm. So this is like Instead of doing that 34 weeks of H plus P that we just talked about, you take that 34 weeks away and you give them Kadcyla times 14. This patient is a higher risk of recurrence, which is the main reason we do this. Okay? 14 cycles, every 3 weeks. All right?
We're replacing the HP.
Replacing HP. This replaces HP.
Replace. The residual disease, right?
Only when patients have residual disease after neoadjuvant treatment. Okay. Does everybody understand the utility of Kadcyla? It's the replacement of HP in the maintenance phase after TCH plus P, if the patient has residual disease. Only if. Otherwise, you just give them HP, maintenance.
Now, I'm not trying to, but when you talk about the residual disease,
Mm-hmm.
is comorbidity?
No, residual disease means that you gave the patient the chemotherapy with the targeted therapy, and it didn't get rid of all of the disease. It still remains.
Oh, okay.
So, in an optimal situation, when you give them the treatment, you really can't detect any more of the disease. It's all gone. But if the patient has some that remains, then you give them a little bit more therapy with the Kadcyla compared to the traditional maintenance with HP. Yeah, so it's HP or Kadcyla depending on how they do post-surgically, if they have disease remaining or if it's all gone. It's 3.6 milligrams per kilogram. It's also a milligram per kilogram dose. It is a monoclonal antibody, although it does have chemotherapy linked to it. 3.6 milligrams per kilogram.
So this one wouldn't last a whole year?
Yeah, no, it's never gonna last a year because it still takes into consideration the Herceptin and pertuzumab that were given previous. Because this is still trastuzumab, this has got chemotherapy bound to it. This is still trastuzumab. Okay? So right now, and this is where I'll end at, I just want to give you the regimen that we typically will give patients who are going to be on, who have triple negative breast cancer. So if y'all talked about, did y'all talk about Keytruda? What do y'all know about Keytruda? It's one of the immunotherapy checkpoint inhibitors that I gave y'all, right? So y'all know that it's part of breast cancer too. It's used in a lot of different disease states, but it's also part of breast cancer. So talk to me, what do y'all know about it? You said what? So in triple negative breast cancer, it's essentially become, in the adjuvant and neoadjuvant setting, it's become standard of care. And what we do with it is we give the Pembro plus Taxol plus Carboplatin. We do this times 4 cycles. Then we do Pembro plus doxorubicin plus cyclophosphamide times 4 cycles. And then finally, Pembro, okay, every 3 weeks. times 9 more. This is weekly. Okay? This is now an AUC of 5. Okay? This is every 3 weeks. This is y'all standard 60 milligrams per meter squared that you guys already know. 600 milligrams per meter squared that you guys already know. The caveat is that's every 3 weeks. And when you say 4 cycles, you know that this 4 cycles pretty much translates to 12 weeks of therapy. And when you say 4 cycles of this, translates to 12 weeks of therapy. And then this is also every 3 weeks, so this is like 27 weeks of therapy. So this is, like I say, any triple negative patients I have at this point that's stage 2 or above, they're gonna get this therapy. Very, very important thing about pembrolizumab is its inflammatory exacerbation throughout the body. I'm talking about head to toe. Gastrointestinal tract, kidneys, lung, liver. So I'm talking about pneumonitis, hepatitis, okay, either uveitis, and even here sometimes called patients that have like blurred vision and fuzzy vision because it causes inflammation in the eyes. One of the most common things I have to do with patients who are on pembrolizumab is their thyroid actually gets inflamed. Okay, so their thyroid gets inflamed and the production of the thyroid gland actually decreases because of the hypothalamic pituitary axis that we talked about before. Okay, but it's affecting TSH as opposed to, we talked quite a bit about luteinizing hormone and gonadotropin releasing hormone previously. We were talking about goserelin and leuprolide. Patients are frequently on levothyroxine when we put them on pembrolizumab if it's affected their thyroid gland in that fashion. So just think about any place that you can have inflammation in the body, you may have to address it with pembrolizumab. You may have to address that if they're on pembrolizumab. But by far the most common thing I have to do is put patients on thyroid replacement therapy to actually help with their thyroid being inflamed and a decreased production of thyroid gland, of thyroid hormone excitement. Okay? So this is your triple negative regimen. As you notice, there's not a lot of different weapons in here. We talked about all of these drugs already. The only thing I've added is the pembrolizumab. And the pembrolizumab is like pertuzumab, is a flat dose, 200 milligrams. It never changes. So, things that I owe y'all. I'm gonna give y'all areas of concentration. It's gonna have a few things that refer to cervical cancer, but we'll discuss them to make sure y'all are very clear on that on Friday. The majority will obviously be breast cancer. I'll also give you guys 3 to 4 problems, probably only 3, because hormone receptor positive, it doesn't matter if they're HER2 positive or HER2 negative. The hormone receptor patients that are positive, they get the same treatment. Their endocrine therapy is the same. It doesn't matter what their HER2 status is. What's different is when they're triple negative versus HER2 positive. So that's a totally different patient. This is the triple negative patient. The HER2 positive patient is that Herceptin with pertuzumab, Kadcyla, all those drugs are the HER2 positive patient. Okay. Also, hormone receptor positive, HER2 negative, we talked about the abemaciclib. That's the only place you see it showing up, is in that patient population. Abemaciclib currently is only approved hormone receptor positive, HER2 negative patient. Yes.
I thought that when they were triple negative, that,
Mhm.
that we could use hormone treatment, right?
Correct.
So why the Pembro?
Pembro is considered immunotherapy.
Oh,
Yeah, the only hormonal treatments that we've discussed thus far, they're more because we haven't introduced anything that's in a metastatic setting, but we talked about aromatase inhibitors, selective estrogen receptor modulators, and luteinizing hormone releasing hormone agonists. Those are the only endocrine therapies that we talked about, and those should be employed in any patient who has HER2 positive, hormone receptor positive disease. Hormone receptor positive disease. And pembrolizumab should only be used in patients who have triple negative breast cancer.
Can you consider using it on the patient that has a lymphoma?
I mean, it doesn't have a lot of data in lymphoma. Yeah. It doesn't have a lot of data in lymphoma. It's usually used for solid tumors for the most part. Lymphoma patients have, rituximab is probably one of the most common things you see with lymphoma patients. Alright. I won't add anything else today, but y'all can digest what we talked about.
Are you just gonna post the AOC to like the announcements?
I'm gonna post the AOC to the course content, and I'm also gonna post the practice problems to the course content today. And I'll look for that email about the calculator to make sure we kind of work out some of these things before I have the exam. Okay? But yeah, you definitely, if there's any questions about it being a scientific calculator or anything of that sort, then it needs to be a scientific calculator if y'all gonna need a scientific calculator for this one. Who had these?